Welcome to my lecture on intestinal obstruction. Intestinal obstruction is quite a common condition that we see in our surgical practice. There are a number of causes, but the clinical presentation is quite simple and straightforward. I shall give a summary into the causes of intestinal obstruction, the clinical presentation, and management. What is intestinal obstruction? Intestinal obstruction is a partial or complete block of the small intestine or large intestine so that the passage of food through the intestinal tract is impeded or obstructed. The diagram here on the left is the normal passage of intestinal contents through its course from the esophagus to the anus. Okay, there is no obstruction, so the passage is smooth. In this diagram here, the passage is blocked by an obstructive lesion somewhere in the small intestine. Thereby, further passage of the food is impeded or blocked. And what happens? The proximal segment becomes dilated, and this is known as the afferent loop. Or it also forms a third space where fluid and gas accumulate and cause it to become very distended. The distal segment, which is distal to the obstructed passage, collapses. Okay, and this is the efferent loop. So this is the simplified explanation of what intestinal obstruction is. Okay, now let's look at the pathogenesis of intestinal obstruction. Okay, this is a picture showing you the intestine. There's a blockage here. Okay, there's a blockage here. So the distal loop or the efferent loop collapses. Therefore, no feces and no flatus is passed. The proximal loop, on the other hand, gets distended, and this distension causes pain for the abdominal pain. Okay, gas and fluid accumulates in this distended afferent loop, and this causes ischemia and possibly even necrosis and gangrene of the bowel. And this space is known as the third space, where fluid and electrolytes are lost into the third space. With this accumulation of fluid and gases here, the pressure within the lumen increases dramatically, and this pushes the contents out forcefully, and this accounts for the vomiting of this patient, which results in loss of fluid and electrolytes. So in these patients, the abdomen becomes distended, there's vomiting of food, bile, and feces. Now, the various stages, on the left here, it shows the phases of pathogenesis that takes place, which as I explained, and the symptoms of these changes will be pain, constipation, vomiting, dehydration, fluid and electrolyte imbalance, and shock. So over here, these are the summary of the changes that take place and the symptoms that the patient develops. As we continue into the pathophysiology of intestinal obstruction, there are two types of obstruction. One is simple mechanical obstruction, where there is blockage, but there is no vascular compromise of the intestine. Okay. Whereas the second one, there is severe complication, which is the severe obstruction with blockage and vascular compromise. So in these patients, the massive distension of the proximal segment due to the accumulation of fluid, gas, and food causes massive dilatation of the segment, causing ischemia of the wall. And this ischemia may progress to gangrene and perforation. And this can also lead to bacterial septicemia. Then there is the so-called closed loop and open loop obstruction. Okay, in closed loop obstruction, which is a very serious condition, there is a formation of a closed loop due to obstruction at two sites adjacent to one another in the same segment of intestine. Okay, there are two here, and for example, in a strangulated inguinal hernia or volvulus, you see there are two ends as obstruction here, and this creates a closed loop where the secretion, gas, and fluid into it causes massive distension and ischemia and possible perforation. Here you can see the proximal dilated segment here and the distal segment which is collapsed. So the main thing is two obstruction points at a single location in the line of the small intestine. Okay, these diagrams help to explain closed and open loop obstructions more effectively, much more easier. Okay, this is the large intestine. There's a block, probably due to a tumor in the sigmoid colon. So the proximal segment distends with gas and fluids and contents of the intestine, and the pressure within it increases. Okay, the ileocecal valve in this case is competent, that is closed. As a result, this pressure cannot be released by pushing the contents into the small intestine. Okay, so this is a closed loop obstruction where this loop here distends very greatly distended and prone to ischemia and perforation. Whereas in this diagram B, the same anatomy is shown here. There's obstruction, the proximal loop distends, but the valve, ileocecal valve, is incompetent. That means it's leaking. As a result, the contents here, the pressure, high pressure contents here, make their way refluxing back into the small intestine, causing dilatation of the small intestine. So the small intestine acts as a buffer to absorb the pressure from the large intestine. So in these patients, there are less risk of strangulation and perforation, gangrene and perforation of the large intestine. Okay, when you do an X-ray in a closed loop obstruction, the cecum will be grossly distended. The sigmoid colon distal to the obstruction will be collapsed, and the small bowel will not be distended. Whereas in an open loop, the large bowel is distended, the sigmoid colon distal to the obstruction will be collapsed. There will be also concurrent dilatation of the small intestine. Therefore, we should be able to diagnose between an open loop and a closed loop intestinal obstruction of the large intestine. Okay, this is a closed loop obstruction. You can see here, where you see double obstruction here, afferent and efferent loops. Okay, and this is a gangrenous bowel, which may perforate anytime. This is a diagram of a volvulus, sigmoid volvulus, where there is strangulation at the twisting of the mesentery of the sigmoid colon, causing blockage or strangulation of this loop here, which is a closed loop. And this, then one area is already becoming gangrenous. Okay, these are the intraluminal, intramural, and extramural causes. Intramural, gallstone, foreign body, and fecal infection. Mural is usually malignancy, malignant lesion, cancer of the colon, inflammatory strictures, intussusception, and diverticular disease. Extramural, a very common cause of intestinal obstruction, especially hernias, adhesion from previous operations, and peritoneal metastasis from intra-abdominal or extra-abdominal malignancies. And volvulus, sigmoid volvulus is the most common cause of large bowel obstruction. Okay, but incidence-wise, the most common is adhesive disease due to adhesions, usually post-operative adhesions, which account for 60% of the cases, neoplasm 20%, and herniation 10%. And herniation, I say, includes inguinal as well as incisional. The other causes, less common, will be inflammatory bowel disease, intussusception, and volvulus. Okay, now what are the symptoms of intestinal obstruction? The cardinal symptoms of intestinal obstruction will be abdominal pain. Okay, most important. And this pain is colicky, okay, and cramping in nature, which is secondary to the active bowel peristalsis against an obstructing lesion. Then you have vomiting, occurs early in the proximal obstructions and late in distal obstructions. Okay. Initially, as I said just now, the contents of the vomiters is gastric or food contents, undigested food, before becoming bilious, and then eventually it may become feculent. Abdominal distension is another important symptom, and it is usually generalized abdominal distension and bloating. Absolute constipation, that means patient is not able to pass stools, unable to pass the flatus as well. That is absolute constipation. This again, it occurs early in distal obstructions and late in proximal obstructions for obvious reasons. And finally, symptoms related to the primary cause of the obstruction. Okay, if the patient has got tumor as the cause of obstruction, then one of the primary cause, one of the symptoms will be passing rectal blood per rectum. Okay. Now, the incidence of the various presenting features, okay, the frequency of occurrence is shown in this table here. Okay, abdominal pain, vomiting, constipation, and abdominal distension are the 4 most common presenting features. Okay, and abdominal distension with tenderness. Okay, sometimes it may be also tenderness, but severe tenderness or generalized tenderness and guarding are severe signs that indicate the probability of strangulation and perforation. What are the signs that you find on examination? First, you have abdominal distension. Okay, abdomen becomes diffusely distended. You may see some peristalsis or distended small intestinal loops, especially patients who are thin and wasted. Patients may have features of dehydration and hypovolemia because the amount of fluid lost into the third space can be tremendous to cause severe dehydration. Then you can have, on palpation, you may have localized or focal tenderness, and sometimes you can also have severe guarding and rebound tenderness on palpation. It must be remembered that patients with bowel obstruction may have abdominal tenderness, okay, mild abdominal tenderness because of the abdominal intestinal distension. But if to have features of guarding and rebound tenderness are uncommon, these are more indicative of ischemia developing in the obstructed segment. So these are very, very important signs that you must look for in a patient with intestinal obstruction. Then on percussion, there's a lot of gas inside the intestine that is distended, so you have tympanic. Okay, it's hyperresonant or tympanic. Okay, auscultation in the early phases usually shows increased vowel sounds, hyperactive vowel sounds. Later it can decrease because of the ileus that is developing, and the classical sounds on auscultation is known as the tinkling vowel sounds, which are sounds which are similar to water in an empty can. Okay, flowing water, movement of water within a can. That is known as a tinkling sound. And finally, you may also have evidence of the underlying disease. For example, previous scars suggestive that adhesion is the cause. Patient may have a mass in the abdomen, or he may look rachitic, suggestive malignancy may be the cause. So these are all features of the underlying cause of the obstruction. Okay, these pictures show abdominal distension of varying degree, maybe generalized distension here. And these two abdominal, we can also see that there are some visible loops of bowel that can be seen, and sometimes you can even feel them. Sometimes you may notice the abnormal colicky movements of these loops that you see. Okay, and then on percussion, you have tympanic or hyporesonant, and on auscultation, you get hyperactive vowel sound, and later becoming tinkling. Okay, so these are all the classical features of an abdomen, which is as intestinal obstruction. Differential diagnosis as listed here: pseudo obstruction, or also known as paralytic ileus, toxic megacolon, severe constipation, especially due to fecal infection, or foreign body blocking in the large intestine, especially the rectum, the left colon, and also at the ileocecal junction. Okay, next we come to pseudo-obstruction of paralytic ileus. As I said, these patients with pseudo-obstruction of paralytic ileus, they have signs and symptoms of intestinal obstruction, but they do not have any physical blockage. So I said it is due to the functional blockage where the movement, motility of the bowel is affected, and this can be by various causes. The common causes will be abdominal or pelvic surgery, the so-called post-operative ileus, can be due to septicemia, due to infection, electrolyte imbalance, especially sodium and potassium, hyponatremia and hypokalemia can cause severe ileus, which may be difficult to treat sometimes. Certain medications, especially tricyclic antidepressants and opioid pain medications, also can cause ileus. Then nerve injuries such as spinal injuries also can cause ileus. Right? These are some of the causes of pseudo-obstruction or paralytic ileus. Okay, what are the investigation you would like to do for these patients? Should be urgent blood investigation, FBC, CRP, renal and liver function tests, and special mention must be made to serum electrolytes. Okay, serum electrolytes must be done and monitored regularly because sodium and potassium tend to be low, and these must be replaced with the fluid that you are giving the patient. Sometimes, if you think suspect strangulation, you may have to group and cross-match blood in reserve in preparation for possible surgery. Arterial blood gases, especially the pH of the blood, will be acidic, and due to the high lactate if there is strangulation and gangrene of the bowel. Blood CNS, culture sensitivity is important to take on admission of the patient, and it is have to emphasize again the importance of monitoring the patient's water and electrolyte balance. Okay, and because of the loss into the third space, and this must be aggressively replaced and monitored. Okay, Otherwise, patient may go into ILS. Now we come to the imaging. What are the imaging modalities that are available for these patients with intestinal obstruction? The most commonly used and still being used is the abdominal X-ray or plain X-ray of the abdomen, also known as AXI. Abdominal X-rays will show a small intestinal obstruction, dilated small bowel, the diameter of the small bowel more than 3 centimeters is considered dilated, and these dilated bowels are located in the center of the abdominal cavity, and you may be able to see valvulae conniventis, which are transverse bands that cross the whole length of the small intestine, which are due to mucosal folds. In large bowel, you will see a dilated large bowel, and dilated large bowel is usually more than 6 centimeters in diameter, considered dilated, and for the cecum it is 9 centimeters in diameter. And this dilated large bowel usually located in the periphery of the abdominal cavity, and the distinguishing feature on X-ray is the presence of hostrations, which are mucosal folds which show up as mucosal folds, as radio-opaque folds that cross the lumen of the large bowel incompletely, does not reach from wall to wall, okay, partial, and these are known as hostras or hostration lines. As I said just now, an incompetent valve will reveal both incompetent ileocecal valve will reveal dilated large and small bowel, whereas a competent one will only show the dilated large bowel and the small bowel will be collapsed. Sometimes you may want to do a chest X-ray at the same time to look for free air under the diaphragm in case there's perforation of the bowel. Okay, these are the two diagrams I would like to show you. This is a small bowel obstruction. Okay, this is small bowel. This is the valvulae conniventis I was telling you, crosses throughout the length of the bowel, transverse length of the bowel, small bowel. And this distended bowel is located in the center of the abdominal cavity. These are large bowel which are located in the periphery, distended large bowel. And these are the hostrations which do not cross completely wall to wall in the large intestine. Okay, so this X-ray is a open loop obstruction of the large bowel in the sigmoid colon area. So the large bowel and small bowel are distended due to a incompetent ileocecal valve. Here again, this is the large bowel and this is the large bowel obstruction in the left side. So it lies in the periphery of the abdominal cavity. These are air fluid levels inside the small bowel, okay, which are also signs of or features of acute intestinal obstruction. Okay, here you see the loops of small bowel occupy the center of the abdomen. Here you see the valvulae conniventis, which are diagnostic of distended small intestine. Okay, and you see it goes from wall to wall. This whole diameter of the small bowel, you see the valvulae conniventis, which differentiates it from the hostra, which is only partial. Okay, can you see? This is hostra, just partial. Just you see, it stops midway, doesn't complete until the end of the other end of the wall of the bowel. Okay, here and this is hostrations, large intestine in the periphery. Okay, the next investigation that I would like to talk about is CT scan. Okay, with IV contrast. Okay, these days CT scan is becoming more useful and more widely used as the treatment or the investigation of choice. Okay, in many hospitals which have that facility. Okay, we find that CT scan is more useful than X-rays in intestinal obstruction. First, it is more sensitive for bowel obstruction. Okay, it detects the distended bowels more accurately. It can differentiate between mechanical, and pseudo obstruction. Okay, if there's an obstructing lesion, it can detect and locate the lesion. It can also determine the site of obstruction. Hence, it's useful in planning the surgery. And fourthly, it's a very useful tool to demonstrate the presence of metastasis by malignancies. Okay, which is again a useful way to determine the treatment the patient should be given. Okay, this is a picture of a CT scan. You see, these are all loops of small intestine. Okay, these are the loops of small intestine, the proximal segment. Here you see air fluid level. There's distended bowel with fluid and air. So this is a clear cut case of small bowel obstruction. Okay, here again small bowel obstruction. This is the distal segment which is collapsed. This the proximal segment is distended. Okay, now we come to this. What is this? Water soluble contrast study? Okay, or also known as contrast fluoroscopy. Okay, this uses fluoroscopic assistance of the fluoroscopic is X-ray study, and this is usually done for patients with adhesions, especially mainly for patients with adhesions as the cause of obstruction. And the solution that is used is known as gastrography, which is water-soluble contrast, which is given orally. Once given you orally, it has two functions. It can predict quite reliably whether the obstruction will resolve with conservative treatment. And this is done by estimating or checking for the time taken for the oral contrast to reach the colon. Normally, you should be within 6 hours. If it is delayed more than 6 hours, then the chances of recovering without surgery is very slim. Okay, and this contrast studies also has got some therapeutic benefit. If it passes through, then the chance of recovering from the obstruction is very much better, very much higher. Okay, that means you can avoid surgery. Okay, this slide shows you the complications of intestinal obstruction. First, bowel ischemia, strangulation, which can be progress very rapidly with tenderness and guarding. So it's a very important sign that you must check for to monitor the patient to see whether he's developing any tenderness and guarding. Bowel perforation leading to fecal peritonitis, which has got a high mortality, especially in patients who are high-risk patients like elderly patients. And this is usually detected clinically with tenderness, guarding, and silent abdomen ileus. All right. Dehydration, signs of dehydration, tachycardia, hypotension, sunken eyes. Then, if it is severe hypovolemia, patient can go into mental confusion, restlessness, drowsy. Okay. Severe hypovolemia can lead to renal impairment, acute renal failure. So you must monitor the patient's urine output. Watch out for oliguria and anuria. And Finally, infection and septicemia. Okay, when the bowel is obstructed, the barrier is obstructed and distended. The barrier for bacteria to migrate through the wall into the circulation is broken, and as a result, patient go into bacteremia and septicemia. So you watch out for fever, with high fevers, with chills and rigors, very important. Okay. Okay, these two factors here are something to think about, which is something very useful. Obstruction due to adhesions are much less serious because in adhesions the chance of developing ischemia and gangrene of the bowel is the risk is very much less. Whereas in a patient with a virgin abdomen, that means patient who has never been operated before, if he or she develops intestinal obstruction, almost always you will end up with surgery because there's higher chance of developing ischemia. Now we come to the management. First we'll look at the principles in the management of intestinal obstruction. Okay, first of all, the definitive management depends on the etiology. Okay, that's very clear. So we have to look for the etiology, determine the cause and treat the cause. And the complications that develop, that's another factor that we have to consider. Okay, and the complications that we are talking about here is bowel ischemia, perforation, and peritonitis. Okay, and then again another factor to consider is the loop type of obstruction. Is it a closed loop obstruction or an open loop obstruction? Okay, closed loop obstruction means there is evidence of ischemia. Okay, and this pain is worsened by the movement, and then there may be fever and pain, especially aggravated by feeding. This is known as intestinal angina. So these are the three important things that you base on the definitive management. Next, other things to consider will be the fluid and electrolyte management, the degree of hypovolemia or dehydration, the degree of fluid loss into the third space. Conservative treatment and surgical treatment. So these are the principles of management of intestinal obstruction. We now come to the treatment of intestinal obstruction. Intestinal obstruction, initial treatment is resuscitation and conservative treatment. Okay, it consists of IV fluids, okay, and electrolytes replacement. As I said, there's a lot of loss into the third space. This must be replaced, and that is the drip. Then to suck out whatever fluid that is retained in the gastrointestinal tract, and this is done by the use of a nasogastric tube, okay, and connecting it to a suction apparatus, and this is known as the suck. Okay, and the patient is kept nil by mouth. Okay, no food or drinks are given, and this mechanism or this method of treatment is known as drip and suck. Okay, drip and suck method of treating conservatively intestinal obstruction. Secondly, you have analgesics and antiemetics must be given, okay, to reduce the pain and stop the vomiting. Antibiotics, usually cephalosporin and metronidazole. Patient must be carefully monitored, okay, while on conservative treatment. Patient is watched for impending complications. Okay, look for signs that will indicate that something serious is happening: fever, tenderness, guarding, ileus, and acidosis. And signs of improvement are quite simple. Symptoms and signs are subsiding or settling down. Then it shows the patient is subsiding. Then surgery should be considered in patients who fail conservative treatment. Okay, and surgery is usually some form of exploratory laparotomy where release of adhesions with or without bowel resection may be indicated. In this respect, it's important that you must know how to distinguish bowel which is viable or non-viable. And finally, after the surgery, post-operative care is equally important. Patient must be monitored, feeding must be delayed, and if there's a stoma must be taken care of. Okay, this diagram shows you the drip and suck regime which I've explained to you earlier. Okay, this is the drip. The patient is on drip. Sometimes he or she may need more than a drip to increase the fluid infusion. This is the nasogastric tube, or NG tube if we call it. The tube inserted through the nose and then push it down, come its opening at the tip of the tip. There's an opening which lies in the stomach. This helps to decompress the stomach and the small intestine, which are the proximal segments that are dilated in bowel obstruction. This nasogastric tube is connected to a suction apparatus, and this can be applied intermittently or continuous depending on the situation. Okay, this slide shows you the use of a nasogastric tube. This is the nasogastric tube which is inserted through the nose and the tip lies in the stomach. Okay, here this is a diagram showing you it passes through the nose and then it is slowly moved down, pushed down into the stomach. Okay, it helps to decompress the stomach and the small intestine, which are dilated due to intestinal obstruction. Okay, for bowel obstruction arising from adhesions of the small bowel due to previous surgery, this is best treated conservatively. Okay, and this is done in this sequence. The first, the patient is treated by drip and suck conservatively for 24 hours, and you monitor the patient. If the patient does not improve, then you can continue to administer oral water-soluble contrast, also called gastrographing, and monitor the time taken for this gastrographing to reach the large intestine. It should reach within 6 hours. If there's a delay more than 6 hours, then this obstruction due to the adhesions is unlikely to resolve conservative treatment. It may need some form of surgery. Another factor to consider for large or small bowel obstruction, whatever it may be, in a patient who has had no previous surgery. Okay, so it is a non-adhesion intestinal obstruction because the abdomen is called virgin abdomen. Such obstructions in virgin abdomen rarely settles without surgery. Okay, once conservative treatment fails, then you got to decide on surgical management. So what are the indications for surgical management? Is a suspicion of intestinal ischemia. That you suspect that strangulation. Okay, I told you the signs that you look for. Fever, that symptoms become worsened suddenly, and the abdomen becomes more distended, more tender, and guarding all over with absence of bowel sounds. All these are signs of peritonitis. So this must be looked for very carefully in a patient who is closely monitored in the ward. Secondly, the indication is a cause that requires correction. For example, there's an obvious cause of a strangulated inguinal hernia or strangulated incisional hernia. So in these patients, you have to go in for surgery. Or if there's a tumor you suspect, you have to go for surgery. The third indication is if patients fail to improve with conservative treatment. Conservative treatment can be tried 48 to a maximum of 72 hours. Drip and suck and replace the fluids, analgesia, give antibiotics, and observe the patient. If for 20 to 48 hours. If within this period it improves, well and good, you continue the conservative treatment till it fully recovers. If within these 48 to or maximum 72 hours, if the patient does not improve or his condition gets worse during this period, then some form of surgery may be necessary. Okay, and in general, most of the time, it will be a form of laparotomy, an exploratory laparotomy to solve this patient's problem. In the laparotomy, maybe resection of the bowel may have to be done because it is gangrenous. So if the resection, if possible, we rejoin primary anastomosis. But if it is not possible, then the stoma, in the form of ileostomy or colostomy, may be done. Often it is a primary, temporary phenomenon. Okay, these are some of the pictures to show you strangulated bowel. This is strangulation, but no gangrene yet. Okay, there's discolored, patient becomes congested and darker in color. Okay, this is strangulation, and this is frank gangrene. This is strangulated here. This segment, this is normal, collapse segment. This is gangrenous segment. This is ischemic segment. Okay, so how you determine this? By the color, motility, and demarcation. Also, you can look for the mesenteric pulsation in the mesentery, and sometimes if it is not, you may use a hot pack to cause vasodilatation and see whether it has an improvement in the color of the intestine. Okay, here again, you can see here, this is gangrenous bowel and this is ischemic bowel. Okay, these are X-ray. This is a closed loop obstruction of the large intestine. This is a sigmoid volvulus. Okay, you see, there's no distension of the small intestine. So these are competent ileocecal valve with large bowel obstruction. This is the same one here. It's a large bowel, sigmoid volvulus. Okay. This is a small bowel CT scan showing you distended loop of small intestine. Okay, that is dilated and maybe strangulated as well. Okay, here again another one. Here a loop of bowel, small intestine. Okay, these are adhesive bands causing narrowing, and this is the neck of the strangulated loop here. Here another strangulated loop of small bowel, edematous walls and dilated. Sigmoid colon, volvulus, closed loop obstruction, but there's no dilated small bowels. Okay, this is a CT scan of the same patient where the sigmoid mesentery is twisted. Okay, and this is known as the whirl sign, WHIRL, whirl sign, whirlwind. Okay, this is the whirlwind sign. Okay, these are X-rays showing the various types of foreign bodies that patients can insert into their rectum, which cause acute obstruction in the rectum, which results in acute large bowel obstruction. Okay, we come to the end now to this lecture on intestinal obstruction. I hope I've impressed on you the importance of diagnosing intestinal obstruction early in order to prevent major complications. A patient who comes with vomiting, constipation, abdominal pain, and is found to have scars over the abdomen, which is grossly distended, always think of acute intestinal obstruction. He has to be investigated with imaging methods which I've described, and always monitor the patient closely for tenderness, guarding, and ileus, which are very important signs of sinister or dangerous complications of intestinal ischemia, gangrene, and perforation. Thank you for joining me during this session. Hope to see you again in another session in the near future. Thank you.